Welcome, everyone. If you will all come together, we're going to start this thing off. You'll all stand for the Pledge of Allegiance. It's going to be led today by the President of the Lubbock Young Democrats, James Keith.
Okay, thanks, Stuart. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, James. I'll now introduce Dr. Lon Jones, who's going to give our introduction today. Please put your hands together for Dr. Jones. Yes, that's pretty bad.
Walk around. Hear me?
Yes, sir.
Very good. I live in Plainview with my wife, Gary Roseman. I've been in Plainview since 1992. I came there to work in their emergency department at the hospital. My 40-plus year career in medicine has been equally divided into family practice and emergency medicine. All of that time in the back of my mind has been the problems that we have in healthcare. Prior to going to medical school, I got a master's degree in the history of science and ideas, and I also have some experience with systems analysis. And systems is what we're dealing with. I made some printouts, but I only did 20 each. So if you can share, I would appreciate it. And that's mine. So there's 2 pages. Take and pass them on. There are basic principles, and the first one, when you get this paper, will be healthcare is complicated. Who said that? Oh, yeah. Right. Now, if you look at that word, complicated, what it actually means is it's a complex system. Now, those of you that are at higher education know what complex systems are. It's not only a complex system, it's made up of adaptable people, so it's a complex adaptive system. And that makes it really hard to deal with. And we wrote a book about complex adaptive systems. It's called The Boys and the Bees. So if any of you want to read it, The Boys and the Bees, it's about how we deal with complex adaptive systems. Don't be afraid of adaptive systems. How many of you are parents? Good. A child is the archetype of an adaptive system. No other organism on the face of the earth adapts from a baby, newborn baby, into the variety of cultures and societies that we have on the earth. They are ideals. So don't get afraid of complex adaptive systems. A child is a complex adaptive system. We are complex adaptive systems. There's no miracle. The problem is trying to figure out how to deal with them, because we like to think mechanically. We learn to connect all the dots. Mathematicians, what happens when you have 5 sets of dots that you try to connect in a matrix? And how many dots do we have in the healthcare system? 20, 30, 40, 100? You cannot predict what the healthcare system will do. Nancy Pelosi was right on the mark when she said we have to pass the Affordable Care Act to see what it does. That's how you have to deal with complex systems. You wait to see. But the problem is, when we pass a law, people out there, when I tell you what to do, what's your response? Usually. You want to find a way to work at that system in those rules that I gave you to benefit you. You game the system. What happens when you game the system? The regulator comes back, oh, look, they're doing this and this. We need more regulation. We need more. So they game those. We need more regulations. Pretty soon you have the Affordable Care Act. How long is the Affordable Care Act? 8 feet. 30,000 pages. Is it complicated? Anyway, there are better ways to deal with it. When you deal with complex systems, the best way to handle them is in a marketplace. A marketplace has all these agents and they can work together without necessarily gaming the system because they're cooperating with each other. But something happened in our healthcare marketplace. Back in the 1950s, we decided that healthcare, well, 1940s and 1930s actually, we decided that healthcare was really expensive, especially when we have hospitals that now we can operate on people and save their lives. That's pretty good. We didn't have that 100 years ago. People died from, or they got stoned on alcohol while somebody cut their leg off so they didn't get gangrene. You know, things like that. But the average life expectancy, 5 minutes. The average life expectancy in 1880 was 45 years, about. The average life expectancy in 1950, 65. Why that increase? That increase happened because mostly of public health. And we found out how to put chlorine in the water and pasteurize our milk and make sure that people had immunization. And the life expectancy improved because our orientation was on, and this is a graph of that life expectancy, because the orientation of the healthcare profession was on making people healthy. Now, what happened in 1950? This graph, this line here, all of a sudden dropped and became level. And if you carry it even further, it levels off even more. Why? What happened?
Healthcare improved.
Say again?
Healthcare improved.
Healthcare improved? Well, maybe, yeah, it did improve.
Sanitation.
So did we find all the answers? I don't think so. I think what happened in 1950 is we started having insurance. And if you look at the Wisconsin Research Institute report from back around that time, no, 1970. Anyway, their conclusion is, and I think I wrote this on your paper, their conclusion is twofold, that people who pay for their health care out of their pocket use about 20 to 30% of if they had insurance, without any decrease in their health care, in their health status. The other thing they found out was that when people do that, they are more empowered, they are part of the system, they are the consumer in a marketplace. And in 1940 and 50, we found out that insurance was a good idea because we didn't want to pay for it. But when you take the consumer out of the marketplace, it exploded. And you have industries then, not individuals. You have industries gaming the system for how we can profit. And you have people like Milton Friedman, who says the purpose of the corporation is to make a profit for the shareholder. What happened to the people that that corporation is serving? What happened to the people in healthcare that the healthcare system should be serving? When we started putting insurance in that marketplace, it took the people out. So, we don't have a voice anymore. It's the insurance companies that run the system. And when the insurance companies run the system, we can't profit. We can't play our game. And we're disempowered. Antonovsky, anybody know Antonovsky? Old guy. Wrote a book, Salutogenesis. What can we do to be healthier? if people have a sense of control, a sense of meaning, a sense of, the other one is the transcendence. But if they have those things, they are healthier. So the question for our healthcare system is, number one, how we can get us back in the marketplace. Number two, how we can build these other elements, a sense of control, a sense of meaning, belonging to this healthcare system. How can we get that back? And we lost it a long time ago. One of the things I really would like to read. Okay. Very good. Sarah Jo Baker was a doctor in New York City. She wrote this book, Fighting for Life. And she graduated from medical school in 1899, right at the beginning of when this increase in our health status started. And she worked in it until about 1930. She tried private practice, but she was a lady and nobody wants a lady doctor. So she went to the New York City Public Health Department and worked there for the rest of her life, for the rest of her practice life. And one of the things that she did to deal with the problems in Hell's Kitchen, which was her part of the city, was to start baby clinics and teach parents and older daughters who took care of the babies to wash their hands when they took care of the baby. That was the major thing that she taught. Now, she writes in her book that she got a memo from the mayor one day. I remember how I felt when, after we had our baby health stations established and doing well in the Brownsville section of Brooklyn, a petition was forwarded to my desk from the mayor's office, signed by 30-odd Brooklyn doctors, protesting bitterly against the Bureau of Child Hygiene because it was ruining medical practice by its results in keeping babies well. And demanding that it be abolished in the interest of the medical profession. Now, do we have doctors like that today?
Yeah,
sure, everywhere. They're always there. They are interested in themselves. They are the priest and the Levite in the Good Samaritan story. How do we breed more Samaritans? Is the question that I have been asking myself a long, long time. Because we need more Samaritans. We need people interested in our health, like they had before insurance. Before doctors started becoming interested in gaming the system to get more of that insurance money in their own pocket. Let's get people back in the system. Now, how do you do that? Another answer, and this is in your papers too. But Ross knew that, writes for the New York Times. He wrote an article, "Make U.S. Singapore," and that's the best answer that I have seen in my experience. The Republicans want to take the Affordable Care Act and dump it. They already have. They want to throw it back at the states so the states can experiment. We don't need experiment. We know good systems. The world has been experimenting. Mayor Bloomberg report. Singapore has the best healthcare system in the world. It is made up, and you can go to the New York Times or Ross House's paper, and you can get on there. There's a book, William Hazeltine's book, Affordable Excellence, which I would highly recommend that you all read. It talks about how Singapore's system is built up. They have health savings accounts. They call it the Unified Fund. You own it. It's not like Social Security, where it's a Ponzi scheme, according to some. But you own this. You can use it to pay for your health care. It's pre-tax. You can use it to pay for your health care, to pay for your education, to pay for a house, things that are socially desirable, and you can do it and you can share it with your family. So it empowers you and us and people that have it. The second thing Singapore has is a public hospital service. And the people there like it just as much as they do their insurance paid hospitals that are private. So How do you get that? Well, our VA system. We have a lot of people that don't have jobs. We need a job corps. If we made a job corps, we would have less people in our jail. We would have more people incentivized to work. We would have more of a focus on our state and our government, because it would be a national job service corps. So we could learn a lot from that. And if they made it so that you would have eligibility to the VA, you'd have public health. So that's how I would like to see it, high in the sky. But to me, it makes a lot of sense. Any questions? Yes.
I remember in the 50s, I'm from West Virginia originally, people died of fuel ears because their family didn't have $5 for hospital.
Yeah.
Now, how do you handle that with savings account? They had no income, they had no money.
Yeah. Savings account needs to be publicly funded until you have enough in it. And tie it in with Medicaid. The people will be eligible for Medicaid. My daughter called me yesterday. I talked to her. She's a nurse in California. They have a baby in their hospital that has no insurance. After 3 days, the bill was $50,000. That's not unusual. What are they going to do? In California, it's a house, and you're up against it. We can't do bankruptcy anymore because of for medical reasons. So, no. Any other questions?
How would we address wait times within the hospitals?
Let's have he's just doing our introduction for us. If you'd like to talk to Dr. Jones afterwards, I'm sure he would appreciate it, but we got to move on to get our candidates up there.
Thank you.
Thank you, Dr. Okay, so now we know where we started from and where we are. Now we want to know where we're going. So I am proud to bring up our two distinguished guests who are candidates running for the Congress. Dr. Dan Epstein and Dr. Miguel Lavarro, come up and introduce yourselves.
All right, well, thanks so much, Stuart. Thanks, Dr. Jones. Thanks, Miguel, and everybody else here for coming. This is really a great event and a great and important opportunity to get into some of the nitty-gritty of the healthcare quote-unquote reform that the Republican Party, including our current Republican Congressman, Mr. Arrington, voted for in the House of Representatives when the bill passed May 4th. So just briefly to introduce myself, I teach political science at Texas Tech. My topics that I specialize in are political parties and elections. But over the years, I've taught about a lot of other aspects of America that really relate to this. I've taught a lot about the social safety net that we have that is a critical part of how we guarantee that whatever background you come from, everybody should have an equal opportunity to share in the blessings that America has to offer. And this is something that is under assault now. I've also taught a lot about how that system is funded in America, how that's different from some of the other countries that Dr. Jones was referring to, and the aspects of the tax system that we'll talk about some here today. But I've also been on the other side of this as somebody who's experienced a lot of different kinds of health insurance, healthcare systems. I myself was on Obamacare in 3 different states. I experienced what it was like to use the health insurance market. My wife, Jasmine, when she was an adjunct at the other university I used to teach at, when we were engaged, she was on Medicaid. And so we experienced what it's like to be in different aspects of the healthcare system besides that part where you just have employer-provided health insurance, which is basically the good part that about half of people in America have, and the other half are in these aspects, these parts of the system that are more difficult. We've experienced that, the in-network, the out-of-network, the complications, $5,000 from the emergency room because you broke your wrist. We know what that's like. We've been in it. And as I said, the other part is the tax system, which this comes into. A lot of people don't like to focus on this because we know who the benefits are going to of this repeal of health insurance. They're going to a lot of really wealthy people, like Congressman Arrington himself, who will benefit enormously in terms of taxes from this Obamacare repeal. Now, when I was my third year in grad school, I was a graduate student. Anybody here been a graduate student? Some of us. You know what kind of money you make as a graduate. I was audited in my third year of grad school, and I had to go through with the IRS back and forth about all kinds of expenses. Since that time, I've been doing more and more complex tax returns for grants that you get, all that stuff. It's the same thing as having a small business. Anybody here have a small business? Few people, yeah, you know, the Schedule C, depreciation, all those kinds of expenses. I've been through a lot of that too. I've been doing this for years. And so this is the kind of thing where not only from the academic side, but also from the side of experiencing different aspects of the healthcare system, different aspects of the tax system. I've been sort of dwelling in this for a lot of years. And I'm so glad that Miguel and Stuart, and we're all here to talk about what exactly are the nitty-gritty details that are going to come out if this bill gets passed by the Senate. We gotta hope it's not, because it's terrible as it is now. And we're here tonight to discuss just exactly how terrible it is. A lot of different topics I want to talk about: pre-existing conditions, about removing the essential health benefits, about how this is going to affect Medicaid cuts, about elderly people, as well as how it's also going to affect people who are on employer-provided health insurance. So I'm not going to go on and on. So I've got a lot of different topics. I hope you guys have a lot of questions, because I've been studying up to give you guys the answers from what is going on in this healthcare system. So thank you.
Good evening. My name is Miguel Levario, and I'm running for U.S. Congress. And I want to thank everyone for coming out tonight. And I think that by everybody being here is that we do have shared experience. You know, we have all shared a similar story to Dan's. Maybe not exactly, but in various ways, whether directly or with family, with friends. The reason we're here is because we're concerned. We're concerned, and the reason I'm here is because I want to listen. Yes, we've all been studying up. We've all been, learning about this bill, because, quite frankly, the reason for it is not just because we want to show off to our friends at our next bar visit or whatever like that, but we want to do it because it affects all of us directly. Everybody here is going to be impacted, just like the world with Obamacare is going to be impacted by Trump care. And that's why we're here. And we're here because we need to protect our communities of life. We need to protect our senior citizens. We need to protect those of us who don't have health care, who are in between jobs. Yeah, I too benefited from public health services, from Planned Parenthood, from family clinics out in the rural areas. Where I grew up, there was only 2,000 people in my town. And when I broke the crown of my tooth, I went to what we call La Familia La Clínica. It's a clinic. It's a publicly funded clinic. That was my only choice because, like Dan, like many of you, I was a grad student or I didn't make a lot of money. So we're all impacted by this. And we're all here because this matters. And it matters to us. And we're here because we want to be there for you. We want to fight for you. We want to protect you. And we need to be the voice, because the guy that's behind me is doing exactly to us what I'm doing to him. He's putting his back to us. I guess with a good head of hair like that, he probably doesn't have much to worry about. But I know I'm a little jealous. I have to throw that in there. But in all seriousness, he's turned his back to us because his vote, his blatant and outward support of this bill, not just with his vote, but going out to that party at the White House, taking his selfie with Ivanka, smiling big, is because he's gonna max out on this.
Yeah.
Not only from his taxes, but also from his business ventures, he's gonna max out on this if this goes through. And he could not care less about you, flat out. That's what I'm here for, because I care about you. Because I care about us. This is our community. Arrington worries more about Washington. I worry more about District 19. Right? So, again, the main focus here is not only to share some ideas, but I want to be here to listen to you, because you don't have that opportunity with this guy. You will have that opportunity with me. Thank you, and we'll open the floor up to some questions, and I'll give it to the master of ceremony here.
Please give talk about candidates a round of applause for those giving the message. Thank you. Justin, for being here. If you don't know, my name is Stuart Williams. I'm the chair of the Lubbock County Democratic Party, and I have the unenviable task today of moderating this town hall. We've got some good talkers up here, myself included, so I'm going to keep it real. And I just want to make you aware of the really, really simple rules. Each candidate is going to have 2 minutes to answer a question. We'll begin the first question. Dan will take it, then Miguel, and then we will, on each question, we'll move back for each candidate. Okay? So if you have a question, we're going to open this up to you. This is what it's all about. If you'll come to this central microphone here, and we'll take those questions. Don't be shy. Don't get all up at once. There we go. There we go.
I'll break the rules by addressing both candidates. It concerns me that we're devoting too much attention to what the others are doing, not enough attention to how we might reform the Affordable Care Act to make it more manageable, that it would be viable, and to promote some discourse between people who stand in the middle. To bother you 1 minute each if you want, but that's my concern. Where are we in the middle?
Okay, this first one will go to Dan.
All right. So what are we going to do? Well, I think, like Bernie Sanders, whose campaign I worked on, I think we need to treat health care as a fundamental human right. Eventually, we need to get to a point where we have a universal single-payer system. We've got one now for people who are over 65 in this country. A lot of them are happy with it. You don't see a lot of people saying, I really wish I'd get off of Medicare and get into... I think we need to have Medicare for all. That has to be our goal. Now, it's a process. It's a long process to get there. I think we need to start by dropping down the eligibility age for Medicare from 65 to 55. I know my mom just barely finally aged onto Medicare. She's had some back problems and shoulder problems, and how much less stressed out my parents are that now she can get her health care through Medicare. So I think that's the first step. But we've also got, as this gentleman was raising the question, what about the rest of the system? What about Obamacare? Well, one thing I'll tell you is that the way Obamacare is constructed now, depending on what your income is, if you are qualified to get some kind of help paying for your premiums on Obamacare, you might have to pay up to 9.6% of your annual income. So if you make $40,000 a year for your family, you might have to pay $4,000 a year before you get any subsidies. Now, I think that is too much. Now, if you make less money, you get a little more subsidy, but I think the first step is we need to reform the system to cut down that maximum amount that people are expected to contribute before they get some subsidies. I think if you had that, I think you'd have a lot more people signing up if it really seemed, maybe we could get our health care for $50, $60 a month instead of $200, $300, $500, $700 a month. And I think that would be a really good first step to try and fix Obamacare, because we've had some problems with that. I think the other is that we need to make sure we preserve what are called the cost-sharing aspects of Obamacare that the Trump administration is trying to cut. These are things that pay extra money to the health insurance companies that cover people on Obamacare to make sure that we can keep the actual out-of-pocket payments low for people with low incomes. And that's a big thing that's being cut. I think we need to increase those. So even if you get this insurance, your actual copay will be a lot lower, maybe like 15 or 20 bucks instead of 40 or 50 bucks. So those are a couple of things that I think can be done and should be done immediately to get more people into the system, more health insurance companies. But in the end, we need to be aiming in the long haul for Medicare for all.
Well, to answer your question, I mean, there's several things that we are very privileged to be in this particular area. I kind of find ourselves at a crossroads of the United States. We're rural and we're urban. So I think to find the middle is not only by looking inward, by looking at the district, the needs of the district, right? We have a very sizable senior citizen community who is going to be bearing the brunt of the cost of Trump care. They're also the ones that are going to be affected the most when we look at capping Medicaid. I myself have a grandmother who is in assisted living, who depends on Medicaid to supply that, to benefit from that service, from that health service. 3/4 of our population, of our seniors, depend on Medicaid for nursing home costs. So we need to look here. We need to look at what our needs are, because they're going to reflect to the country. And we can use this area as a model to the way that we get to universal health care, Medicare for all. What we have to do also is preserve the major step that the Affordable Care Act made. We cannot go backwards. It's exactly what Trump care is doing. It's going backwards. But Obamacare is here. It's not going anywhere. Whatever comes out of the Senate, whatever eventually comes out of both of the Congress, there's going to be elements of the Affordable Care Act there. So we have it. But we need to preserve the benefits and the positives of that plan for us to move forward, so we can get towards where we would like to be ideally. You know, we have a lot of good in the Affordable Care Act. We have the fact that, you know, the federal government is willing to support states with more funds when it comes to Medicaid expansion. I'm emphasizing Medicaid a lot, not only because it helps our poor, but our district is a rural district, and it depends heavily on Medicaid. Because it's not just to providing health care to the poor, but there's also flexibility in Medicaid that allows our rural clinics and our other hospitals to be able to extend health services to those who can't afford it, or those with unique situations that need a unique type of care that Medicaid can cover. Capping it or these block grants is not going to allow us to do that. So we can look inward to find that middle ground and to preserve what good we have, making it so we can get to the long end, to the end of the road when it comes to Medicare for all.
Could you say your name, please?
My name is Jessie. My question is, how will it change Obamacare tax reforms that support health care?
And this question will go first to Miguel.
Can you explain that a little bit? I'm not sure if I'm following your question.
I'm wondering, how will it change the Obama tax reforms that support the health care?
Well, okay, very good, okay. What we have now with the AHCA is it's basically a tax cut for the rich. That's all we're looking at. We're not looking at any real healthcare reform. We're not even really looking at any real insurance reform at all. It simply goes down to a tax cut for the rich. And also by eliminating the individual and the employer mandate, it's also going to allow a lot of insurance companies to grade their different policies however they want to. It's going to also give the option to employers so they can say, you know what, we're not going to extend healthcare to you. It's not going to be a benefit you have this job when you have this job. So there's going to be a huge impact, not only on individuals, but mostly on those of us who are middle class and working class families who are going to bear the brunt of it, right? The tax cuts going to the elite was meant to cover some of the costs. So what Obamacare was trying to do was basically for all of us to share the burden, right? And by cutting taxes for the rich, they're not going to share the burden at all. Because number one, they can afford health care. They make money, they can afford it. And now they're going to make money on top of that because they're getting their tax cut. Well, we're still stuck holding the bag as middle class and working class families. They benefit at our expense. That's what it comes down to. So when we look at Trump care, we have to see it as a tax cut for the rich, because that's essentially what it does. Because all the other mandates or all the other elements of the Affordable Care Act that share that burden are going to be repealed or changed so much, that, such as, for example, Medicaid, are going to change so much that they're really not going to benefit any of us really at the end. Right? And the ones that bear the burden are your poor and your working class families, especially your working poor. That's what's going to bear the brunt.
So Miguel's exactly right that, you know, one thing we don't think about a lot of time is that Obamacare, when it passed, was also a tax reform. That since the 1980s, we've been cutting taxes for the wealthiest people in our society year after year, decade after decade, and in the Obama administration, the one way that a little bit of that was clawed back was through Obamacare. So people who make, if your family makes over $250,000 a year, which, no surprise, that's just about where our current congressman's income is, you're going to, under Obamacare, you now had to pay, if you had investment income, which already you don't have to pay any payroll taxes on, you were going to have to pay an extra 3.8% on your investment income. Now that's a lot of money to help shore up Obamacare. It paid for Medicaid expansion, it paid for the subsidies in the individual markets, and that came from people who have enormous income from stocks and bonds and bond trading to actually require them, you need to put a little bit more skin into this system in this country to support the whole country. That's going to be gone. So it's going to be a huge benefit for the investor class if they make over $250,000 a year. The other aspect is that Medicare, which Medicare itself is going to be having problems in the future. There's a trust fund that funds Medicare now that more people have been paying more money into years ago, and now there's more money going out. Obamacare imposed for people who make over $250,000 a year on that income over that, an extra 0.9%, not even 1% of their income. Actually, they have to pay in a payroll tax to help support Medicare. That's one of the major things that's going to help Medicare be around for another 20, 30, 50, 100 years, and that's going to be eliminated too. So we're cutting off a major source for Medicare in the future by passing this Trump care.
Hi, my name is Evan Grimm. What about essential health services like prenatal care, mental health coverage, and contraceptives?
Next question, go to Dan.
Okay. Yeah, well, so these are things that when Obamacare passed as well, there was a mandate that all health insurance offered through the individual market that Obamacare set up, as well as employer-provided health care plans, had to cover a whole bunch of different things. Contraceptives, had to cover coverage for women, giving birth, having babies, mental health care, which has gone to support substance abuse programs. And with Trump Care, we now have a loophole where states, and you can bet which states are going to try and do this, can ask for a waiver. So they don't have to, so insurance providers in this state don't have to require all these things. And you know what's going to happen? Health care for men who don't need to necessarily have coverage for having a baby themselves, that's going to be offered at a lot cheaper rate, whereas women are going to have to pay more for health care. And we can see that with waivers like this, to eliminate the need for these coverage, that the federal protection guaranteed for all of us, we're going to be taking more and more money out of the pockets, just like Miguel said, out of the pockets of the working poor, especially out of women's pockets, as we're going to be constantly requiring them to pay more and more for health care while men get off with a better deal. That is not fair, that is not American, and that is not what we are going to accept.
That's a very important question because, here in the district, we are in a bad spot, and especially in the state. One of the things we need to look at is that this healthcare initiative is a shared responsibility between the federal government and the state. And Dan's right. We are unfortunately living in a state that really couldn't care less about us when it comes to our healthcare. We rank at the bottom pretty much in every medical category there is, from uninsured to access to healthcare, and obviously with their emphasis on defunding Planned Parenthood is going to impact a number of individuals, not just in Lubbock or Abilene, but in our rural areas. So this Trump Care is going to take away, in some way, shape, or form, whether it's the waivers that Dan was talking about, or the fact that they're implementing in the Trump Care itself that they will not fund or limit the funding to Planned Parenthood, it has more impact on us than we can imagine. Because it's during these, what we call community clinics, that offer mammograms, pap smears, basic healthcare services, and in many cases, preventive healthcare services. With a healthier community, we have less people going to the doctor. And what are they doing? The complete opposite of that. They're taking away those services therefore essentially or potentially making us sicker, and therefore sticking us with the bill at the end. How is that supportive of a community of life? It's not. So what we have to understand is that our state, when Jody Arrington says the states can handle this better than the federal government, that's what he loves to say, right? Well, we live in a state that ranks at the bottom when it comes to medical care. That's not good for us, right? We had Rick Perry, when the ACA was passed, Rick Perry called the expansion of Medicaid and federal funding for that expansion the grossest intrusion to state sovereignty. I mean, imagine that right now. That's what we're faced with. So we look at these preventive care measures. They're being cut out and are going to be limited at the very best, going to be limited. And it's probably just for those of us who live in bigger cities like Lubbock or Abilene. But what about our neighbors and friends out in Post? They matter too. They matter too. And how about the help? And then we have to go that far. Go across the other side of the freeway. What about them? Right? So we need yes, we have to be aware of that. This is about going after. I mean, the Trump care has very little regard to women's health. They certainly put themselves in higher regard, and that impacts all of us. We have, I believe I'm not mistaken, our demographics. We have more women in this district than we do men. So guess who's going to bear the brunt of that? Thank you.
Thank you, brother.
My name is Clive James, and I've got a question concerning pre-existing conditions. We hear this talked about a lot. People talk about pre-existing conditions were excluded from exclusion with Obamacare and so forth. Can you each tell us specifically exactly how the elimination of the provisions on pre-existing conditions in Obamacare. In other words, under Obamacare, you cannot exclude a person from health care because of pre-existing conditions. Can you try to envision an individual person or family and tell us what it would mean to a person or a family with a pre-existing condition if this man Trump's ideas were put into law?
So one of the things that Trump care does is it's going to eliminate the community ratings policy, which means that you cannot discriminate individually to people, especially with pre-existing conditions or on age or anything like that. Trump care eliminates that. So it allows insurance companies or states to basically give you a variety of different packages, and of course the cheapest package is going to offer the least amount of services. So with pre-existing conditions, you're going to be subject to, which is Arrington and Congress are saying, we're not eliminating pre-existing conditions. But they're putting a big asterisk next to it saying, when you have it, you're going to pay for it. Right. You are going to pay for it. Not the rich, not those who want to do, you are going to pay for that. So you're going to be left with the worst package possible, and so they're indirectly, and I would say directly, discriminating against you because of your pre-existing condition and because of your age. Those are the two people who stand to lose a lot as well when it comes to this new Trump care, right? So when we look at that, by limiting that community ratings policy, it allows the insurance companies to make out like bandits. It really does. Because with the Affordable Care Act, you cannot discriminate based on pre-existing condition or by age. The Trump care is getting rid of that. But they're saying, we're not going to keep you out if you have pre-existing condition, but what they're not saying is you're going to pay for it. Right. I mean, they're very, very clear about that. We're keeping that from the Obamacare. No, you're not. No, you're not. You're discriminating based on that. That's exactly what they're doing. So I think that we need to be very much aware of what we mean. And the pre-existing condition can range from a variety of different conditions. It's not just you're born with something. It could be anything. It really is very generally defined in order for them to loosely discriminate. I mean, I'm an immigration historian. And when we started passing immigration restriction laws, they would literally put in the restriction the feeble-minded, the confused. It's like, well, I mean, I drive in Lubbock every day and there's a lot of confused people. But what they did in general, what they did that on purpose was so that the officer had the leverage to distinguish who he will let in and who he wouldn't. That's exactly what this does. Right? I know I'm probably over time. Sorry.
Pre-existing condition guarantee that you could get insurance through the individual market under Obamacare said that, like Miguel said, everybody, depending on your age, you couldn't charge people more or less. You had to charge them the same amount by age. And supposedly, this is still going to be in Trump Care, but again, as with the essential benefits, there's going to be the opportunity for states to get a waiver so that they can waive that requirement that insurance companies on the individual markets give people just insurance that might cover something, might not. So when I was in grad school, I had to be on one of these individual markets in the years before Obamacare. And later, I remember watching Sicko, that movie. You guys have probably all seen it. And what they do with these pre-existing conditions is, after you've already been paying for the health insurance for a long time, if they can discover, once you actually need to use it, that you had maybe acne or asthma that you hadn't reported, maybe you had trouble with other kinds of aspects of your personal health that maybe you didn't want to talk about on forms or with doctors when you were applying for insurance, and they would find these things out after the fact and then cancel your insurance right when you actually needed to use it. So it is this capacity for being arbitrary. The other thing they can do is if they find somebody they know, this person probably has a condition like a heart condition or hypertension, they will be able to, these insurance companies, just jack up the price of your health insurance policy to it where it costs $1,000, $2,000, $3,000, $5,000, $10,000 per month. And so, in theory, you still are offered a plan, but it's preposterous to think that you would buy it. So it is a way of discriminating against people. And they have some ideas of how they're going to solve this by what they call high-risk pools. But all the estimates for high-risk pools say it's going to take about $15 to $20 billion per year in order to cover people who can't get affordable insurance. Trump is going to give about $1 billion, and that's it.
Thank you. Thank you both for being here. I really appreciate it. My name is John Bartow, and I'm an associate professor at Texas Tech. And I, the other day, got a letter from Mr. Arrington on health care, as a matter of fact. And I wanted to just read a couple of sentences. As you know, as Texans are largely served by rural and community hospitals. And since the Affordable Care Act was implemented, 80 rural hospitals have closed nationwide, and 600 more are in danger of closing. We must focus on patient-centered options in order to attain affordable health care in the United States. Well, it seems to me, would I be correct to say that probably the main problem for rural hospitals is the refusal of Texas to expand Medicaid, which is a Republican policy. And is there anything in the proposed bill, the one that's gone over to the Senate, that would do anything to help rural hospitals that you know of? And what would you do about rural hospitals?
This question will go to Dan.
So the first question, is there anything in this bill that no is the answer? There is not thought about rural hospitals. There is not thought about what about people in places where there aren't enough doctors, where there aren't enough nurses. Doctors and nurses can get paid much higher wages if they come here and they work at TTU Health Center than if they work in places like Big Spring, where I was yesterday. If they work in places like Young County, way out there at the other end of the district. And so this problem, John, you're exactly right that the failure to expand Medicaid has kept lots of people. There's over 100,000 people in this district who still do not have health insurance. Is it because they don't want it? Not likely. Not likely. These are people who, I bet you would like some health insurance. I would like it. Yeah, I've had it, it can be good at times. But this is what we need to expand Medicaid in order that people have the coverage that allows rural hospitals to be able to serve patients in poorer communities and be able to be guaranteed they're going to get paid for it by Medicaid instead of having to wait, instead of people in lower income who don't have insurance having to wait till they get sicker and sicker and sicker, then go to the emergency room, which is much more expensive, and then the hospitals If they have to provide this care and they can't get paid for it because people don't have insurance, this is what is forcing rural hospitals to close. And we need we need a multi-pronged approach. I think we need to have some serious thought to how we reward doctors and nurses who choose to go and practice in more rural areas, in places like Castro or Yoakum, or parts of the district where they're having trouble getting enough people to work in these hospitals. And I know that one aspect that we could do, we have public work student loan forgiveness, which is also about to be eliminated by the Trump budget, that we could extend and encourage a greater degree of of loan forgiveness from student loans for doctors and nurses who choose to go and serve these underserved communities. And that's one thing I would fight for in Congress.
Well, John, I think your point is very important. I think it emphasizes the idea that this is a shared responsibility between the federal government and the state. And one thing that Texas has made clear, as I said before, is that they don't care about us. They have actively rejected any federal funding to expand Medicaid. There is no doubt that it's the failure to expand Medicaid in the state of Texas that has caused those closings, and we essentially close the rest of that are left behind after Trump care is passed. There's no question about that. I think what we need to do is not only try to, we need to, well, one thing is that the state needs to prioritize health care, which is going to be a long road. One way we do that is by voting, first of all, is getting the leadership that care about these out. Okay, but I think what we also have to understand is that when we look at our rural areas, right now they're having to, I mean, they can potentially have to travel 2 to 3 or 4 hours to get basic care. This isn't just like they were in a horrible accident and they have to fly somewhere very specific. No, this is for basic care. And that's what the Texas rejecting the expansion of Medicaid has done to them, right? And so they don't care. So that's why Jody doesn't care about rural hospitals. He doesn't care. Right now, what Trump care is trying to do is what they call Medicaid block grants. Set amount given to each state, and that's it. It won't adjust. It won't go up. It won't go down. But it won't move. Now, what it doesn't do is it doesn't apply to what if there's another economic downturn, which is going to happen. As an historian, trust me, it's going to happen. I'm going to blow it. There's a ruined ending right there. It's going to happen, right? When people start losing their jobs and they're going to have to apply for Medicaid, the state's going to be like, well, we're out of money. We can't extend that to you. So there is a trajectory that's downward when it comes to the way that both the way the state of Texas has rejected expanded Medicaid, and the way that we've looked, and the way Trump care is basically saying we don't care at all, right? The other thing is, as I've said before in other places, both here in Lubbock and in Abilene, is that we need to look at incentivizing our nurses and doctors to go to rural areas. I mean, if we can get the funding there, they still need to staff them. They need to staff those hospitals. And one of the main groups that's actually looking into rural medicine and family practice are our immigrant doctors. So this is where we tie in. We look at immigrant bans and all that the Trump administration is doing. It's actually impacting many of our doctors from the Middle East who are actually in the rural hospitals or in the socioeconomically low socioeconomic areas. They're in those hospitals. That's where they can get their training. So we have all this connected. But by providing loan forgiveness, we incentivize, because that's a big burden on our young people right now. Walking out of a bachelor's degree with $20,000 of debt. And that's out of Texas Tech. That isn't Harvard. I mean, Harvard's a private university. I went to a private university too, so it's not Notre Dame or Harvard. Texas Tech is a little bit lower in price, but they're walking out with $20,000 of debt. Right? So we look at our doctors who are walking out with 6-figure debts. We can keep them here, not necessarily in Lubbock, but they can work in Sweetwater, they can work in Plainview, and we can keep our talent here and not have a brain drain of any sort, because we can help with loan forgiveness or other types of incentives.
I'm T.G. Caraway, and I'm going to be running for county commissioner here in Lubbock, so I got to sit down with Commissioner Flores a couple of weeks ago. We talked about talking about something that's going to affect, Trump care is going to affect a great deal. There's about $60 million that goes into the Lubbock County Institute health care program that goes to UMC. And I know that's through Medicaid. And I know that there's a lot of cuts. How much cuts does he want to do in Medicaid?
$800 billion.
$800 billion, something like that. So I think, you can tell right then and there that, that's going to affect Lubbock County greatly if those cuts are done. I like what Miguel and both of y'all been talking about, that, if we do go to the block grants, which that's what they want to do, they're going to the block grants. Well, we've seen what Governor Abbott, how he works with any budget that, over the last 3 bienniums, he's cut the budget by 5% every year, so there's been a 15% cut in the state budget, and that's what I'm sure that's exactly what he wants to do with these block grants. What do y'all feel about that?
This will go to Miguel.
So the thing that we say about block grants, block grants historically don't work, and then we've seen, there's been the Republican president since Reagan. They've tried to pass some sort of block grants during their administrations, and they've failed miserably. Because the fact of the matter is that because they're inflexible, they will not adjust to changes. As Dr. Jones was mentioned, they're not adaptive. They're not adaptive systems. They're set. So when we have another economic downturn, if God forbid we have an epidemic of some sort, the block grants will not adjust to that need. So again, we're back to where we're stuck holding the bag, or basically we're stuck to just fend for ourselves, right? So it's important to understand that we have, and this has been a long program and a long idea from the other side, but it's also proven to not work. And one of the things that Dr. Jones mentioned that I want to harp on is that we have a profit-driven healthcare system. The fact that we have a privatized stakeholder healthcare system is inherently unproductive. You cannot serve two masters. And you know what? Since the fact that the other master is a stockholder, we can pretty much forget about it. Unless you're a stockholder, then you're making out pretty well. So that's the problem with that, is that we have